examine the critical factors in ensuring responsible AI implementation, and outline the roadmap for future advancements in the sector. And for this session, we have with us the convener and moderator, Dr. Vidur Mahajan, Chief Executive Officer, Carpali.ai. Hi, welcome. We have the esteemed speakers with us, Dr. Rakesh Mullik, Chief Scientist, Artificial Intelligence and Precision Health, GE Healthcare. Welcome, sir. We also have Dr. Kritika Rangarajan, Associate Professor of Radiology at All India Institute of Medical Sciences, New Delhi. Welcome, ma'am. We have Mr. Rohit Mahajan, Director, Asia Commercial Operations Intuitive. Welcome. We have Mr. Asad Kumar Vidyarthi, Co-founder and CEO, Prodog.ai. Welcome, sir. And last but not the least, we have Dr. Anna Fonpok. Please welcome, madam. She is the Global Head for KPMG International. Welcome. Can we, as a mark of respect, extend a warm welcome to all of them? Thank you so much. And I now request Dr. Vidur to take over, please. Thank you.
Thank you so much, ma'am. And thank you, FICCI, for giving me this opportunity. I have been MIA in all of the FICCI stuff for a while, but still, still you think of me. It's an honor, it's a privilege. Hosting a session with superstars on AI makes it easy, makes my job easy, makes it also very difficult to stick to time. So because I can have individual hour-long conversations with each of the folks here. I think the way we'll run this conversation, of course, is going to be very interactive. So anybody in the audience at any point in time, if you have any question whatsoever, any thought, just raise your hand, start speaking. We'll send a mic over or whatever, we'll make it work. You don't need to. We will keep some 15 odd minutes at the end for Q&A, but if there is a thought that comes to you, just interject. In fact, that would be really nice. Same thing applies to all of us. If you hear something, as I was telling the panel earlier, that the ideal outcome is that two people fight. So, and hopefully they don't involve any AI in the fight, because that'll just make it very interesting. So we are going to talk about two threads over the next hour or so that we have. How much time do we have, organizers? Sorry, anybody here? Okay, perfect, done, sir. Yeah. Dr. Lal has said so, I'll have to adhere. Okay, perfect. So we have a lot of time. So so we'll do it, in basically two threads. One thread would be maybe more dominating than the other, which is basically the role of AI. What are we seeing happen in India? What are we seeing happen globally? What can we learn? Everybody here has very, very unique perspective on that. And the second is, something that is my personal passion, is what can we take from India to the world in terms of AI, and what are some of the unique facets that India has to offer globally. And since we have a global audience, hopefully some of that actually does translate. So without further ado, I would start by requesting Dr. Anna Van Pook. Anna, would love for you to share your thoughts, as the global leader of KPMG. I think I overheard you're in 70 countries or something like that. Possibly, I was telling her, KPMG probably touches everyone alive in one way or another, and thereby, so do you. So would love to hear your view from the top, if I may, on where are you seeing AI today globally, and then would also, where do you see India fit into that mix, and what if we can learn anything and like that. So take it away.
Thank you. Well, I hope we touch everybody's life, because me and my colleagues, our ambition is really to improve health and healthcare across the globe. So if we touch everybody, that would be great. So what are we seeing in the field of AI in this world? We had a big conference. Actually, in the last 3 weeks, I've been doing Brazil, Saudi Arabia, and Europe, a big convenement in Europe. So that's a bit of a tour across the world. And AI is really getting big, and I've been in this sector for over 30 years, and I've never expected such a huge transformation and change to take place within the field of healthcare. It's really transformational what is happening. Now, in order to see the benefits, in order to reap on the benefits, I think we have to sort of analyze a little bit where are we seeing AI happening and where are we seeing AI having its greatest benefits. And I can start at the first point is AI helping us to have a much more proactive, personalized and preventative approach of healthcare. So if I look at that, the first part is we see AI having a more and more important role in population health. And I'm going to take you on a little bit of a world tour because for me an experience say more than a thousand words. One of the most far-fetching examples that I'm seeing in the field of population health and prevention now is happening in Israel, where one of their HMOs, so that's a vertical insurer and provider, has 5 million insured. They have a very long history of electronic medical records. They are running 5 million electronic medical records through their machine learning at night. And in the morning, 2,500 GPs get an overview of which patients are at risk, who to reach out to, who to look at, who to take care of. And that's for me, that's really turning healthcare upside down from being a curation-driven field of play to a real preventative field of play. So that's one. The second one is helping staff and helping leverage on what you can deliver. We all know that there's a huge shortage of nurses worldwide. Hippocratic AI has developed an approach which is based on very extensive AI tooling, very extensively tested. And what they do is they have a proactive pre-screening, post-screening, pre-intervention, pro-intervention, and preventative outreach. So let me give you one example here, what they do, and it's a chatbot. It's a very well-trained chatbot in different languages, by the way. One insurer in the US, when they had an extreme heat wave, made the chatbot do 200,000 calls a day to their vulnerable population. The chatbot was asking questions, and based on the situation, was even giving preventative advices, or was sending an Uber to the homes of these people to bring them to a cooling center. And that's a real preventative approach. Then one which helps in processing patients much quicker is what Israel is doing is they had a huge rise in post-traumatic stress disorders. Given the situation in there now, they had a shortage of psychologists and psychiatrists. Together with Microsoft, we developed as KPMG an AI tool that is doing the triaging, the diagnosing, and the setting up of the treatment plans. And that's now being done in 1/5 of the time of what you normally do. So this is all that's happening in the field of AI in terms of caregiving, front office caregiving. The other big benefit is improving the efficiency of your organization. And just a few examples there. One is Leeds Medical University Center, where we had a whole analysis of what could be AI, looking at back office, administrators, HR officers, but also front office. We come together at about 10% of all workforce that can be saved because, and it's not taking over core roles, it's taking over administrative tasks, it's taking over routine tasks. So the whole efficiency issue is going to be a very, very big gain. And then using
if I may, Anna, just one question, right? As you're telling us all of these examples, and they're like mind-blowing to say the least. What does it take from an infrastructure perspective to actually implement, something like the Israel, like 5 million people every day getting processed, and the GP knowing what to do at the start of the day, or making 200,000 calls, right? From an infrastructure readiness, because one can assume that, we will now have access to all the AI that anybody has access to. So what is it that enables, this?
Yeah, for either insurers or for providers, it means that you have a very good data infrastructure. Without a good data infrastructure, it's going to be very hard. Does it have to be all top standards? No. Depending on what you have in terms of data infrastructure, you can decide where to start. The Israeli example, of course, only works if you have all the electronic medical records, if you can process them, if you have the links to the GPs. However, we're also having examples where we have data on the use of surgeries, and we're using AI now to optimize the use of surgeries. The 200,000 calls means that you have to have a very good call center, that you have to have a very good overview of your patients and insights into what is the vulnerable part of the population, but a lot of data is already available. And then, of course, you have to have a very good repository where you keep the data, and then you have to have the links. So when the patients come to the cooling center, it helps when the information is already there. So data exchanges need to be in place, data infrastructure needs to be in place. It helps a lot if you have electronic medical records, but even without electronic medical records, a lot can be done already.
So what can we then, you have like the Indian healthcare leadership essentially sitting in front of you here. What should they do, tomorrow morning, and then maybe 6 months later? What should they do to enable such use cases? Just the possibility that they can even be executed.
Yeah, the last thing I would advise anybody is to react to every offer that they get and start buying AI like, a madman, because then you're going to get a situation where, as we say in Dutch, you can't see the trees through the forest. So you need to be very specific. You need to be very specific in what I would say 3 key questions. One is, what is the most problematic field that you have where AI can be of real benefit? So if workforce issues, start doing that. If vulnerable populations are your issue, start working that. If your capacity use is a problem, start doing that. So be very specific on what strategic goals do we want to achieve. And the second one is make a selection based on what you have in place in terms of data infrastructure. Getting your data infrastructure into place is to something, I think, like 20 years ago, we all wanted to have hospital built, so we needed to have wards and operating theaters and diagnostic centers. I think the challenge of tomorrow is not so much, of course you need to have a certain level of physical infrastructure, but your data infrastructure and your digital infrastructure is going to be key. But don't overestimate yourself. Start small. Start with a lot of what I would say small experiments, small proof of concepts, but don't let it be a situation where everybody can do whatever they want. Have a very good sort of like take your key pockets where you want to grow, where you want to really use AI, and then make it a very strong, organize it in a very disciplined way.
No, that's very simple but yet very insightful, right? Like only take on a project that you can actually do, as opposed to just trying to do everything and not getting it. No, thank you, Anna. As I said before, I can keep talking to everybody for the entire time. But I think from population health and global learnings, we could go to Rohit, right? Why don't you? So Rohit runs, Intuitive Surgical, not just in India, but also Japan, Korea, China. And surgery, it has always been touted as one of the safe areas for medicine, right? One of the things that will probably not get disrupted by AI. So when are the robots taking over, Rohit?
So that's a good question. So in fact, if you trace down the history of robotics or history of intuitive or computer-assisted surgery, we were born digital. That's what we say, that the day we started surgery, we had access to that data throughout the surgery. So it's the system data, it's the kinematic data, and it's all that happens during the surgery. That's really. So robots are not taking over yet. But what I'm gonna definitely say.
I'm just gonna pause for 1 sec. Who here knows what he's talking about? Like surgical robots, like does everybody here know what they are? Or yeah. So why don't you give like a 30-second thing on what are surgical
I
robots?
saw Dr. Panigrahi and I assume that everybody is kind of aware of. So, let me talk about the history of surgery. So, several years, centuries back, we used to have open surgery. Yes? So you make incision and, then those are large incisions. And then you operate inside the anatomy of the patient. In the 1970s, we came up with laparoscopic surgery, which is also called minimally invasive surgery. By 1990, it became a very popular modality where you were doing keyhole surgery. So there were these small ports, and you were, the surgeon was sitting or standing, on the side of the patient. Through a 2D camera, was able to move these instruments through those ports. In 1995, when Intuitive was founded, we came up with robotic-assisted surgery. Now, with robotic-assisted surgery, what happens is that the surgeon, so the robot is not doing the surgery, it's the surgeon who's doing the surgery, but the robot has its arms, which are docked over the patient. Again, we have ports on the patient's body. And through these arms, you have instruments which go inside. And there are three main things, and you have a 3D HD monitor where you can see the anatomy, and you can maneuver the instruments sitting on a console, which is not close to it's a little far from the patient. So, now the surgeon has, more dexterity, better vision, and higher precision because of this, the visual as well as the ability to maneuver those instruments inside the patient body. So that's been the journey of surgery overall. And now, autonomous surgery is the most debated topic. Whenever I meet my friends, everybody asks me the same questions. Well, they say if people can think about automated cars, why don't they think about robots? It's different. It's different for surgery. But I also wanted to say a little bit more about what Intuitive and what is the AI use case, right, specifically for robotic-assisted surgery. If you look at, we all know AI is going to really revolutionize the future of surgery, patient care, but this all is going to happen through this constant virtual cycle of innovation and evidence. Now that evidence is going to be fed through AI, ML, and surgical data science, right? Historically, when a surgeon went into an operation theater, they had access to either the patient factor or the disease factor, right? And they were able to look at outcomes which were either intraoperative, meaning before the surgery, or postoperative, which mean after the surgery, right? But with robotic-assisted surgery, what happens now is that the surgeon has access to everything that happens during the surgery, right? And so we at Intuitive now have access, and we are analyzing 3 different kinds of data. First is to know what the surgeon is doing during the surgery. Second is to know what the surgeon is looking at the vision. And third is to know what really a good surgery looks like. All of this data eventually helps us build tools which will help the surgeons through training and rigorous practice, right? And we have 3 key opportunities in terms of the areas for surgeons through this data. First one is reducing variability and improving patient outcomes, right? Through the artificial intelligence, machine learning, and improved processing power, and the fact that now the surgeon is able to access this data from millions of patients. They have all these algorithms from AI which helps them reduce this variability and helps improve patient outcomes. The second is OPIs. As you all AI experts know, these objective performance indicators, these are basically metrics or parameters which really define or are coming out of robotic surgery system data, kinematics data, and that surgical video which we are capturing during the surgery. And all of this eventually helps the surgeons benchmark it to expert surgeons and help them with their learning. The third and the most important use case for AI is lifelong learning. So now for the surgeons, what we're able to do in robotic-assisted surgery is we are able to access that intraoperative surgery. We are able to connect it with outcomes, long-term and short-term patient outcomes. And our team of analysts and data scientists are able to then recommend to, let's say, a novice or an expert surgeon, what are the steps that they need to perhaps do in order to become better at what they are doing right now. So that is honestly the biggest use case for AI in robotic surgery.
And that is pretty incredible. And I think, as somebody who is fairly unaware of that side of AI, it's incredible that the use cases, as now we know, are so niche and so nuanced. I do have one question for you, Rohit, and we talked about it. So Rohit runs the China business sitting here in India. So I thought maybe we can get some secrets of or what China has done well from him. So what does a hospital in China look like from an AI digital health perspective? What can we learn? What does Japan, Korea, which are maybe less opaque in that sense? But since you run those businesses, from a AI digital health perspective, how different is it there, if at all it is, and what can we learn from them?
That's a great question, Vidur. I would say that I would first take the AI out of it, and I would say that all these markets, and because you brought up China, very different policy setup, very different provider setup, different way in which they run. A typical hospital in China has 5,000 beds. So first of all, when I walk
typical hospital.
Yeah, I mean many of them, many of them have huge. So they look like AIMS, as Kritika's hospital. So what they do very differently, especially in China, is that they are experts in operational efficiency. So what we've seen for us at Intuitive is that the highest number of procedures done annually is actually in China, and it is whopping 1,800 procedures in a year. This is
using the surgical.
surgery.
What would the number be in India? Like
in India, it's actually Dr. Panigrai's hospital, which is around 800 procedures.
Of the same machine.
With the same machine. So they and to your question again, what is it about digital and what is it about AI? I think at the core, what the Chinese do much better is that they beat the efficiency really well. So their care teams, their nursing staff, their nights and weekends is extremely optimized, and they run it like a machine, and they use AI, they use digital. They are much ahead of what we would think of, like a more East Asian kind of a setup. So they leverage all of those tools to be much better at that operational efficiency. When it comes to the adoption of and hence, if you look at the use of robotic assisted surgery too, outside of the US, China is our second biggest market. So they've really led from the front in adopting newer technologies, being open to digital AI and health tech, and that's what is visible now.
So is it then just, Rohit, is it a mindset thing only, or are there like some like governance frameworks, etc., also that drive the efficiency? Because I'm sure, like an Apollo would want to derive as much efficiency, and many of us here also pride ourselves on how much, at least in the world of radiology, we are able to run our MRs and CTs, but this just seems like it's a 2x kind of delta.
So that's a great question. So it's it starts with mindset, of course. They perhaps want to be world leaders. If you go into the history of China, they always want to be better than the US. They're always competing against the US, so they definitely want to set those standards. But what they've also done is, I think they've very neatly laid down the frameworks. So when you peel down the onion, you would see that these frameworks, or how these protocols are being run. There is a hospital in Guangzhou, which is actually our world's most leading operational efficiency site. We get our care teams from across the world there. They have laid down frameworks and their models so well in terms of touching all these stakeholders. So it's not just the surgeons, it is the nursing, it is the anesthesia, it's everyone who touches the patient, right? Which is different in different countries. Like, in India, we're more still focused on the surgeon and maybe the anesthesiologist, but not too much on the care team, for example. But they have standardized it, across all these stakeholders. And that's where I think they really excel.
Just so much to learn, and yeah, these are some mind-blowing stats. Like average hospital, 5,000 beds. No, thank you, Rohit. So moving on to Rakesh. Again, I'll do this. Okay. Uh, so Rakesh, you kind of, if I may say, run at least for us AI at GE, and GE is, of course, world's largest manufacturer of big iron, if I may say. So what is GE up to in AI, and what does the world look like with if you were to have your way?
Yeah. Thanks, Vidur, and thanks for this opportunity to be at Wiki. Yeah, I think GE, and I'll do some course correction here. We are now GE Healthcare, so we are a startup, but with a body perhaps of old company, 100-plus-year-old company, which does the big iron stuff. So, as a lot of you have seen, the move from analog to digital. A similar move is happening from digital to AI. What are you focused on? You want to get more productivity, you want to get more efficiency, you want to get standardized care, you want to reduce cost. Similar shift is happening now to go beyond AI, to agentic AI, to Gen AI, and elements of that form. So what we are realizing is that, yes, the big iron is important, and we are right now, I think, third year in a row, the leading producer of AI solutions, as rated by the ACR. Some people may not like ACR, but they are keeping the compendium of how many FDA cleared AI solutions are out there. It takes some to build that AI, and we are leading that pack. But we are realizing that we can build hundreds of these models, right? But what they are doing right now is only scratching the surface of the number of models that needs to be built in the healthcare enterprise. Now, a lot of us still think of they are doing the radiology diagnosis, but the models are doing a lot more out there right now. Right from the manufacturing of the machine, having a deep understanding of the domain itself, and trying to leverage that. We just saw the Nobel Award given out to AlphaFold 2. So there's a lot happening in basic science. There's a lot happening in how you create systems, solutions, and to Anna's point that a lot depends on the data. And what we are seeing today, and these are estimates published out there, that by 2025, the world today would be generating 180 zettabytes of data. Now, it's a large number to cope with. The interesting thing is that a third of that data is estimated to be healthcare data. But the most intriguing part of that is that 97% of that data is not being used. It's there. You talked about operational data at surgical. There is operational data in the hospital. There is data all across. There are reports all over the place. So what we are trying to do at this point is trying to see, can AI help us go through that data and give us better insights to address the same set of problems of how do we create standardized and quality care, bring affordability into the system, as well as provision access.
So
that
Rakesh,
is sort of
sorry,
the focus.
just quick interjection. 5 years ago to today, right? In terms of pure capability of analyzing the data, what has changed?
I think what we have realized, and this is I guess the teething problems that we went through, is establishing solutions for data governance, first and foremost, right? Managing the data, establishing fair practices of how we deploy AI, how do we monitor AI. I won't say very little of at least the clinical AI is run in closed loop manner, where feedback is coming back for all the challenges that data governance brings into it. At the same time, what we are seeing is the significant enhancements that's happening in the computing space, the transformation that we are seeing even in the Indian healthcare system of people leapfrogging to a completely digital infrastructure. So that data is becoming available, but it still has to be governed, it has to be managed, and then you need to build the trust to be able to deliver that. So that's the big shift that we are seeing. Now, from a pure technical point of view, I'm a scientist, been there for the healthcare system now, with GE Healthcare 25 years. The transformation we are seeing is, we are trying to see what we can do with multimodal data sets, multimodal models, which are now what are quoted as generative AI models. Can they be one model, right, at the base of it, so that you're not going out there and fiddling with hundreds of these models, updating all of these models? I know it's a good business for Carpal, evaluating all of these models, because these models will need to change. As somebody recently pointed out, this was from the FDA itself, it says we got to think of these models really in different manner. Even our own clinical practitioners, and Kritika can comment on it, they go through continuing medical education. There is constant training that is happening. So your models will have to be retrained. They'll have to be reevaluated. They'll have to go through MLE evaluations or whatever it is to see, are they ready to serve the population today? Are they continuing to be safe? So we are trying to transform ourselves in that space, and a lot of that is happening with the availability of compute over the cloud, availability of access of this data.
That's pretty incredible, and maybe in due course I will go deeper into some of that. But Rakesh, just one thing, and I'd said that we will briefly touch on this. There are also hundreds, if not thousands, of scientists at GE, at your competitors, Philips, Siemens, even Nvidia, Amazon, all of these companies working on AI technologies, sitting in India for the world. What is the significance of that for us?
I think the morning session pointed out on the importance of it. I think TTI was brought up as one of the elements of what will make Viksit Bharat happen. I think building the talent.
What is TTI? Sorry, I
So
wasn't there. Morning.
So infrastructure was the I in there. Infrastructure is also resources, but the training element of it, the elements of having the data around. I'll forget what the exact talent, technology, and infrastructure. Yeah. So all of that sort of comes together in what you're saying, right? I'm sitting in Bangalore, I'm in the middle of all of this, where we are seeing there is very, very significant talent. I was fortunate last week to be at the NVIDIA AI Summit in Mumbai, and it was just energizing, very energizing to see the large number of startups who are putting in all their effort to build these solutions, right? And they are, we are seeing a lot of transformation that is happening.
We couldn't even get passes, like
it was
paid
hard.
passes.
I was with the person who was, being asked, I know so and so, can you get me in? It was very fortunate to be there and to hear out what the leadership across the globe is thinking. And the thought process is that we are going to, and some of you must have caught up all the sound bites on CNBC or elsewhere, that the thought process is that we are going to be now exporting intelligence. This is the mode that we are shifting to, right? We are going away from sharing our data and getting and importing intelligence and moving into a direction where we are in a mode to, and the infrastructure is coming up very, very rapidly. We're going to get the Blackwell solution in Jamnagar and all that activity that's happening. So it is very exciting to be in that space, but it takes some to build in different domains. In gaming, in other infrastructure, elements. When we bring in AI, it's a very different story. Healthcare is super special. At least to me, it is very, very special, and it takes some. I'll from my own experience, we are in the process of trying to get a truly, validated, and this was also part of the morning discussion of how do you get validated solutions out there to ensure safety, and we are in that process still to get the first validated solution out there, which is leveraging Gen AI out there. For tasks which are productivity tasks, we are not trying to make clinical decisions, but even for productivity tasks, the steps and processes that have to be taken from transferring data from your infrastructure to a third-party provider of models, to ensuring cyber security, there are tall challenges. They can be overcome, but it requires some time, and we are sort of, right now going with an icebreaker, trying to figure out all of those pieces to ensure that when we go up to FDA, when we go up to environments which are regulatory bodies, that these are watertight, they are foolproof, and have the right guardrails in there. So there are those challenges. Yeah.
No, wonderful. No, thank you, Rakesh. I always try whenever I'm running these panel discussions to not make it, 5 speeches essentially. But I guess when you have, people who are so articulate and amazing, there is no other way. So yeah, so that's just my defense mechanism. Next, Kritika, you wear 2 hats, if I may. 3 hats. One is being a very close friend. Then second, being a physician. You're an oncoradiologist at AIIMS. And then thirdly, you're also a PhD in AI from IIT. And I don't know whether you consider yourself a scientist or an engineer or both. And also you've received the recent, grant of the Center of Excellence from the government for, that is like an AI Center of Excellence has been set up at AIIMS, the Healthcare AI Center of Excellence. So when you, as a clinician, when you listen to all of this and when you delve into the world of AI, what excites you the most?
Thanks, Badur. Thank you, and thanks, Vicky, for having me here. So I think, so when you begin looking at it as a clinician, the first thing you feel is excitement, because you're looking at how much can be transformed by AI. And today with the large language models, ChatGPT being so accessible, there's an explosion of things and of ideas that do not require you to typically reach out. Like, even with the previous generation of AI, where at least you had to reach out to a collaborator to make it happen. Today you're in a situation where you have enough compute in your pocket. You have an app which is going to sort of help you test very random use cases for you, which you can simply do without needing to reach out to anybody else. So I think, taking from the topic of this entire discussion, this is truly democratization in some sense, right? So it's available for you. You have a thought. You can actually see how it's going to play out in the clinical spectrum today. At the same time, I think what you do feel, a lot of clinicians feeling, is also a sense of fear. And I think that's not something that you want to brush under the carpet. There is, truly a sense of fear. To begin with, it was radiologists and all the image reading specialties, because that's where AI was. And slowly also moving towards other specialties now. When you talk about, ChatGPT clearing USMLE and things like that, it truly can do a lot of what you sort of did and what you were sort of held up, at a pedestal for. But at the same time, when you kind of go over the excitement and then go over the fear, then comes that sort of realization of both responsibility and of a sense of how you are in a place where you can truly guide where healthcare should go, what healthcare should look like 5 years from now. Even 10 years is too much to imagine in today's day. Because AI is no longer truly an engineering problem in today's day, I would say that. There are plenty of models which are very accessible to all of us. And the challenge here is, how do you implement it within your system? So the challenge is, how do you safely put in the guardrails to ensure that it is more useful to you than harmful to your patient? So again, the operationalization.
Could you give some examples of, like from a clinical perspective, AI that you've used or, tried to use?
Yeah, so I think a lot of us try to imagine, use cases where it's replacing the doctor. Does it actually manage to make that correct diagnosis? But short of that, I think there are a lot of very interesting examples, for example, where, so as radiologists, and I am a radiologist, there are a lot of very accomplished radiologists here. So the thing is, how many times do you get to meet a radiologist? So all of us, possibly have gone through a CT scan, an MRI, an ultrasound. So you've all gone through radiological modalities, but have you ever met a radiologist? How many times have you understood that report that you've sort of received from a radiologist? And then, take this into a situation like AIMS, where most of our patients don't even speak English. So what you're getting is a lot of medical jargon. You have no idea what is written. And this is going to basically determine what's going to be done with you, right? So this is one example where we tried to sort of simplify these radiology reports. We tried converting these into Hindi and giving it out to our patients. And we did a user study where we were able to show that a simple intervention like that actually massively improved patient compliance. Patients loved it. They loved understanding what they had. In a very similar sort of experiment, which was kind of an extension of this, we said, why should a patient not meet a radiologist? So is it possible to have an OPD setting where you can go through a radiological investigation, maybe you go through a mammography, and then you walk into the OPD of a radiologist. The radiologist is actually explaining your findings to you in simple Hindi, and this is not even English, and the report actually gets transcribed on the background. In no time. So it's an editable report, but you can basically sign it out and give it out to the patient. So the patient has actually now understood the investigation and is participating in the treatment along with you. And similarly, you spoke about education. So again, on the education front, for example, where a radiologist typically takes years to actually see an entire spectrum of findings, which is why it's so difficult, right? So when you look at mammograms, detecting subtle cancers is very difficult, whereas detecting overt cancers is very easy. Like anybody, even with an untrained eye, can do it. So we said, why not generate and allow a user to actually generate mammograms of all kind and put up cancers in different regions of the breast so that you get a visual impression of what the cancer is really going to look like. So these are just some examples, short of really replacing a doctor or doing that fancy thing of coming up with a real medical diagnosis, which can truly transform some of the very core problems of healthcare today.
Yeah, if I could comment, because you asked this question also to Rohit about autonomous surgery, autonomous radiologist. I think if you look at the one autonomous vehicle that we want to put out there, it's taking its time, right? There are going to be pieces that are going to come along the way, right? You're going to have, bumper protection, lane assist, cruise control, safety of all sorts. So it's a process of happening. It's not, and that is not the be all and end all. There is so much opportunity in the healthcare infrastructure and, that operational efficiency to get and serve 5,000 beds out there, that, there is ample room and space. It doesn't have to be, and this has been oft quoted, that, anybody, and this is now anybody who's not using AI is falling behind in some way or the other. It's literally that.
Well, I'll just add to that, in fact, that when you look at what a radiologist is going to do 5 years from now, it's going to be very different from what a radiologist does today. So often the fear sort of arises from believing that you're going to continue to do what you are today, because a lot of what you're doing today will get replaced by AI. But we as humans evolve, so you will be doing something different, which is very similar to when MR came in, right? So when MR came in, everybody believed that these images are so clear, we don't need radiologists to interpret this any longer. But so many years into MR now, you've thrown more data at it, and it's probably the most formidable sort of imaging modality, which definitely needs you to be very specialized to read. So again, I mean, we as humans and as experts need to evolve, which we probably will as time goes forward.
Yes, Anna, please.
Yeah, I think listening to this, I think this is all very, very good, and I like that phrase, like, start using AI now, because if you don't do it now, you'll be out of business in about 5 years, which is a certain point. It also means for leaders in healthcare that they do not only need to rethink the investment in data infrastructure, but they need to rethink their ecosystem, because a lot of healthcare will not only be democratized, but also put down to lower levels. So primary healthcare, community care, social workers will take over quite a lot of the roles being held by AI. So start rethinking your ecosystem and the data infrastructure, not only in terms of your own organization, but that whole ecosystem, and start working around that. That's one. And I think the second one is all about education and trust and governance. The big risk in AI is that we democratize it so far that it becomes a tool in the hand of people where maybe we don't want to be the tool, and where we erode trust rather than we build trust. So I think training our medical professionals and all clinicians to work with AI, to use it, to adopt it, be less resistant, start trusting it, that's one. But at the same time also build these very high levels of trust, government regulation. So what do you accept to come into your market? What don't you accept to come into your market? So we need to start rethinking both at the governance and trust level, medical educational level, organizational level, and your data infrastructure level. I think leaders will need to rethink quite a bit from now.
And that's very, very well said. In fact, my personal view on the replacement discussion is obviously augmentation, but exponential augmentation. And I say this with a lot of humility, with Dr. Lal and Om sir here in the room, kind of transformed pathology in this country, and we call it the pathology analogy, where you have one pathologist signing out thousands of tests a day. You put in blood, you get out a number, auto sign out, subject to controls, right? Subject to all the standard deviations, etc. So how do you get a radiologist at AIMS with a line of a queue of like 500 patients outside? So how do you get one radiologist to be signing out 500 mammograms a day, right, as opposed to 20 that happen right now on the backing of AI? Because the demand is certainly there. So yeah, so we're I think everybody's trying to figure out those mechanisms. Yeah, Rohit, please, yes.
Sorry. No, I was on the point what Anna raised around responsible AI, right? So I want to talk about a use case, and we were speaking briefly about it earlier. We in the area of surgery, we heard a lot about telesurgery. Now, there's so many Chinese companies which came up with their claims that sitting in New York, you could do surgery for a patient in London, right? So transatlantic, trans-Pacific, and whatnot. So when we and people like Rakesh sir are intuitive, when they went into details and took a deep dive of what truly this is, we felt that the biggest use case, or the most safe use case, perhaps is around telecollaboration. It's not too much about telesurgery, because in telesurgery, you're taking that risk. You're not being responsible. What if something happens to that patient, right? And you're sitting transatlantic and there's nobody in the room. But when you call it telecollaboration, what you're doing is you are maybe mentoring another junior surgeon who is in London, and you're in New York, and now you're able to guide them and move them towards maybe doing a better surgery, right? So like Rakesh also said that it's maybe phases and steps, but taking them more responsibly is perhaps an onus that most organizations today have.
Oh, that's awesome. I think collaboration versus replacement again. Yeah. Awesome. Going to move on to Asit now. So Asit, you are a startup founder. The thing we are all best at is pitching our startups. So why don't you start by just telling us what ProcDoc does?
Yeah, so Vidur, thank you for that. See, we have heard a lot of applications of AI. We have seen a robotic surgery. We are talking about data points. What Vidur is doing in imaging with AI is just phenomenal. But what ProcDoc does with AI is something which is a need of ours for every patient. So what we have built is a patient engagement platform. So what it does is it allows patients to have the right care discovery. It allows patients to have an care journey. It allows them to have appointments. So let me give you a few cases where you could think the problem statement, and then probably as a solution where AI is going to come in. So say we all go consult a doctor, and by the time we just go sit back in our car, that's when we realize we have another 10 questions to ask to the doctor. Now imagine the pain points that you will have with that kind. So that's where AI comes in. Again, another thing is most of the hospitals are basically moving around an acute healthcare. They want, if there is a surgery, they would probably do it to the best. But there are a lot of pre and post surgical treatments that the hospital itself offers. But what is happening is because the acute care is their primary focus, there are already so many in line waiting for acute care. If AI is able to give you a suggestive care that, okay, fine, after this surgery, this is the physiotherapy cycle that you have to go. Now again, example, another very good example, somebody who is in the maternity cycle, when they are probably in the first trimester, you put them into a patient care journey, and then it's like all of you must have got this messages, for you it's time to go and take a flight. Probably you should leave your home, right? So now in the entire care journey, if we are able to kind of put an AI for your care journey saying that next week you are going to have your scanning due, this is the time where you should be going to. In fact, I've seen hospitals using Prodoc where they do a standard health checkup, and by the next year at the same time, it says, oh, this is the health checkup that probably you should get into. So care journeys, care discoveries. And interestingly with Prodoc, what is happening is, it is multilinguistic. So for example, what I would say is, somebody sitting in Northeast, probably a doctor would have made 100 of videos and put it on YouTube, right? And for me as a patient, if I go to an hospital and all I know is my daughter has a stomachache, right? And I don't know what to do. I go to a big hospital with 500 bed, there are more than 200 doctors there. So I go blank what to do next. So using AI, probably so again, there have been chatbots, right? Where you can probably go select, and ultimately it will take you to the call center. But what we have built is a small model language with all rate cards. In a way, how it operates is, if I say I have fever, it will not say go and have Dolo. It will tell you, this is, so in my case, so if the daughter is not well and she has a leg pain, then it will probably pick up and ask you questions, since how long? Oh, is there a swelling? And I think you should look at a pediatric orthopedic, and that's the suggestion that it will give. And parallelly, it will give, oh, pediatric surgeons, these are the pediatric surgeons available. Do you want to book an appointment? And interestingly, what we have done with Prodoc is, we have just used the entire system in the back end and build it with the most easy thing that is available, something like WhatsApp or SMS. So you can have all this using AI. Most importantly, so what it does is, in an hospital setup, it is going to help all of you to do what you can do more better, right?
So, Ashit, I have a question, right? I think everybody here may have seen now WhatsApp has AI built into it, right? You can kind of just press. In fact, it forces you to use it. बहुत बार गलती से दब जाता है, and then you start getting answers for questions, existential questions. So
if there is a query about a particular surgery, then it will post that particular surgery's video, which is already there, and say, why don't you have a look at it? We have done spine surgeries and the patient is out in next 2 days. So this is the confidence building of the patient engagement that you can do with Prodoc. You can have question answers that you can ask the doctor, and the question is going back to
the patient thinks they are chatting with the hospital. Like it's not that the patient doesn't know there is Prodoc.
Correct. So there's no Prodoc out here. So in India, for every one doctor, there are 1,450 population of people that needs to be attended. Now, interestingly, with Prodoc, a doctor cannot consult or probably treat more than one patient at a time. But what it allows is, at the same time, we can probably, there are 100 patients talking to the same doctor and getting an information about the problem that they have. In fact, very interestingly, I'll just like to share this story. We started Prodoc around 3.5 years back. My co-founder's dad was going through cancer, and with all the education and access to internet, everything, we didn't know that who is the doctor whom we need to go. All we knew is, for cancer, you have to go to an onco. But the specific thing is, it was a neck and cancer case, and we didn't know that there is a doctor very specifically available for that. Today, interestingly, you put that data, probably just put up your scan, you can take voice messages, everything on WhatsApp app for the hospital which is there on Prodoc, and it will suggest you that this is the doctor, you should probably visit a head and neck cancer onco specialist.
That's amazing.
So that's
that
how
is
we started Prodoc.
truly democratizing, access to intellect, if I may say. Let's open it up now. Questions, thoughts, comments. Yes, please. I don't know if we have a 6 minutes more.
Hi, I'm Amrit from HCG Bangalore. I am a biostatistician by training, and just by the time we started to wrap our head around the p-values and getting into neural network, the whole field of AI and ML came around and built up a whole new storm. So with this regard, I think probably my question is, right now we see that there is a higher variability in healthcare data as opposed to, let's say, fintech or automobile driving data. I'm not very sure about that, but healthcare data, especially when it comes to mental health or whether it comes to oncology, the variability within data sets is much higher, owing not just to individual differences, but also cultural, ethnic differences. And with the paucity of data that there is, and the variability in the clinical decision that naturally is taken. So not every radiologist is the same, not every pathologist is the same, not every clinical decision, not every oncologist takes the same decision. How do I validate which AI algorithm to use, how do I evaluate a startup that comes to our organization to understand whether they are using a right algorithm or not? And basically, how do I kind of put this into perspective of, is there kind of a grading system or a checklist that we can put in from the healthcare organizations to say that AI-based startups or AI-based systems have a certain set criteria? I think more on the regulatory front, or probably just to look at validating the data.
Kritika, you want to take that? Maybe? I don't know. Or
Want to say something? Please go ahead.
I'll get a user to talk about it.
I think that's a very interesting question, and as a statistician, it takes from the same principles, which is you do need to train with a very large amount of data. That's why data is key. And like you said, because of the variability that you have in terms of the interpretation, what's also very important is how was that ground truth generated. So it's garbage in, garbage out. If it's trained with stuff which was not strictly validated, then you will not get a very good answer. In terms of where the field is moving, I think that's why we're seeing a lot of foundational models coming in. So you have models which are trained on lot of data, which is just thrown into it. It's not really specific to a very particular use case. But then these models learn to recognize this data. They recognize the patterns in the data. They understand what CTs are. They understand what medical imaging generally is. And then on top of that, you train it with some specific sort of smaller data sets. And generally it works. So that's how the field is moving per se. And then as far as your question on how do you select one particular model is concerned, I think that's a much harder question. I think that's for a lot of that responsibility needs to be shouldered by the agencies which actually approve. So as an agency, like as DGHS or as US FDA, how do I decide whether this particular network or this particular model gets a go-ahead? Is a very important question that they can solve at their end. And then when it comes to you, you're already getting an approved model. You should be able to look at the statistics. There should be, I think there's also a problem with balancing how much you give away as a startup, how much you're willing to reveal about how the model was trained versus how much you want to sort of keep away from, you want to protect your IP because it is, you have to be sustainable at the end of the day. But the answer somewhere has to lie with the regulatory agencies. And then, you can take a trial of it, in your specific hospital. you do need to always validate it in your setting to see how it's functioning, and then you sort of, take a
I
call
think
on
Dr.
that.
Panigrai had a question, sorry.
In fact, the data that India produces is huge.
Sir, Mike.
Yeah. But we're not collecting the data in the format that everyone can see. So I think so this is something that FICCI, I want to just put it on the table, is that we need to have it, whether it's private sector, public sector, or patient data, because the NVIDIA CEO was mentioning that like India is the IT services leader. It can be an AI leader also. But our data is all across. So I think that's one. And Rohit, I'm just marketing it for you. Your robotic, it's a 3D image that you see. Laparoscopic is 2D.
Nice. Yeah, Dr. Mahajan. Ma'am also.
Hi, I have a question. I'm an architect. We design healthcare facilities. And right here.
Sorry.
I'm here. You want me to stand? And I know right now we are designing a facility where we are talking about creating a digital twin to improve the quality of care, the quality of patient outcomes. How far is India from doing something like this? And what are the capex, or what is the operating cost? Ma'am, to you, Anna. What are we looking at? Has it been done here?
Well, I wouldn't be, I'll take this one. I wouldn't be the right person to answer about where India is exactly. Maybe I want to reflect a little bit on that first question and then come back to you. And that's more of an appeal to the whole ecosystem as you're sitting here. What we're seeing now is that in the US, there is the Coalition of Health AI Institutes. And in Europe, we're seeing the emergence of the TRAIN network. And TRAIN is the Trusted and Responsible AI Network. And that goes exactly into the question, how trusted is AI? How responsible is AI? I was sitting the other day in a presentation by one of the big tech providers, and he had Gen AI generated images. And he had an image like, I'm giving a speech to a room full of KPMG consultants. Guess what? It was an image of all males. That means that his AI hadn't been trained very well, because I happen to know that we have some female consultants in KPMG. So it means that if India wants to move up, and actually I think India is in an excellent position to move up. You can leapfrog. India is at a very high speed transforming a healthcare system. There is a huge opportunity to leapfrog and getting to a much more digital age at a very high speed. But it comes with a huge responsibility, and it also comes with a huge duty to together create something like that trusted and responsible AI network. So you work together. You can still be each other's competitors, but like, what are we allowing in the market? What are we not allowing in the market? How are we helping our staff to work with it? How are we helping GPs to use the right AI? Now, if it comes to the digital twins, I think we have some examples, mainly US-based, where the digital twins are pretty far. I think the issue still is you need to be able to make very precise twins of the person that you're trying to mimic. And that's where a lot of the difficulty gets into, like, how are you going to get all the data? Because it's not only about the genotypical data, it's also about the environmental data. How are reacting people to the environment? So yes, it's doable, but I think till now it's still a pretty hard one. It's exciting because it's going to make healthcare totally preventative, but it's a hard one to get all the data together. But I would definitely sort of like in a proof of concept model and maybe do parts of the individual, start with certain disease patterns. But it is an exciting road, and I think digital twins are going to be pretty far and leading in healthcare in the future.
Nice. We have a comment from ma'am and then final word from Dr. Mahajan.
I have a small question.
Please.
I'm an armed forces veteran, having served all over the country. So in this vast country itself, although I've traveled abroad, the demographic differences between patients' disease presentation and even the way they respond, their socio-cultural differences are so stark that I'm wondering how an AI tool, which is not manufactured within India and does not have the database which is 100% complete and error-free, how will it generate a diagnostic advice or a treatment advice which is as good or better than a good clinician?
See,
Allow Dr.
your
Mahajan
question
to
is
answer.
very similar to the question asked earlier, which was on which AI would work well in my hospital, in my center. There is not going to be one AI which is going to solve the problem. It may be a different AI in AIMS, a different AI in Safjang Hospital just across the road, because the way we image, the way we treat may be very different. Two, it may be a different AI which will work in the ICU, and a different AI in the OPD, and a different AI for your inpatients. You know, the demographic differences, the patient differences, the equipment differences, all of them matter. And that's why, you know, we've seen ad nauseum someone claiming 98% accuracy, and it's not even 50% when we use it. So in a way, a solution is there. Vidur is sitting there, which is a platform approach to deploying AI. And his platform actually happens to be the first in the world to get US FDA. And there are multiple. You can load as many AI. There are 900 plus AI algorithms which are US FDA approved today. Maybe every day as we speak, the number increases. And so using a platform approach, your own radiologist is able to test which out of those 20 AI algorithms available for a chest X-ray, all of them being US FDA approved. So it's not that US FDA or a DGHS approved algorithm is the be all or the end all. You will have to test it on your own data and then be able to use it. So the tools are there, and I think in the years to come, there will be at least 300-400 AI algorithms used in radiology department itself, and maybe hundreds more, if not thousands, in other departments. So the only way can be through a platform, and already India developed one which is US FDA approved.
Sir, I think I am getting very bad looks.
Those are AI looks.
They're very much real, sir. No, but thank you so much. You know, these discussions can always go long, and I'm glad I could get my dad to pitch my product. Nothing better than that. It was his idea, though. But yes, no, thank you, Anna, Kritika, Rakesh, Rohit, Asit. Thank you, Vicky, for giving me this opportunity. And yes, thank you so much.
Thank you, Vidur, and thank you all the panelists for that wonderful presentation. And ladies and gentlemen, we now have the oral paper presentations to be held over here.